Guys, after subscribing to this channel, please make sure that you also press the bell icon so that no notification, no new video of mine, any educational video, is missed
Okay.
by anybody.
Now, what about the mode of delivery? So in placenta previa, you know what is the mode of delivery, right? Placental abruption grade 2 onwards needs expedited delivery to salvage the fetus if possible, but suggested to reduce the maternal complications mortality. After diagnosis of abruption, the patient should deliver within 6 to 8 hours. See, this is not a hard and fast rule. Placental abruption, how much? That is number one. Placental abruption, less than 20%, with mother stable, fetus stable, you don't have to expedite the delivery. But the proper placental abruption before you reach the grade 3, you have to deliver the baby. No exact timeline. Relative evidence suggests usually delay is associated with more morbidity and plausible complications. So non-salvageable fetus is better delivered vaginally. Obviously, so the baby is dead, you go ahead to deliver vaginally. Amniotropy is the first recourse in abruption when delivery is planned to reduce the intrauterine pressure and thus reduce the backflow from plasma to the circulation and reduce the trigger of DIC. So what happens in abruption, guys, is that if you deliver the baby, then the backflow of all the toxic thromboplastin material that can somebody help this girl, Sana? Just help her join the class. Just tell her how to join the class. Just ask her to go back to the main channel and just click on join and she'll be able to join it. Or if you can just put in the link of the class, then she'll be able to join from here only. Jitu, if you're there in the class, Jitu, are you there? So please just, if you can just post the link of the class, maybe she'll be able to join. And though we are towards the end, but there are certain take-home messages that I'll be giving you towards the end, which is very, very important. Because when you're reading a chapter from any book, they are not as organized as I would want to be. So this is just a chapter which we have like discussed today, but the take-home messages I'll organize towards the end. Okay, let's read it first and then I'll tell you. So what happens is that when it is a dead baby and it is abruption, you cannot salvage the baby. You better deliver her vaginally if the mother is stable. So most important is maternal stability. Then of course the cause. What is the cause? Then the fetus, how the fetus is doing, and the gestational age equally. Correct? Both are equally important. So if the baby is non-salvageable, you already know that the baby is dead. There is no point in gestational age assessment right now. If you know the cause is not placenta previa, you go ahead to deliver the baby vaginally. If it's placenta previa, you cannot deliver her. You cannot deliver the baby vaginally. If you're delivering the baby through ARM, you know that since you're rupturing the membranes, the whole gush of fluid will go out and it will not seep back and cause more DIC. Now, it also helps in reducing the surface of placental separation by reducing the stretch and inducing uterine contraction. So once you've done the ARM, the whole pressure, it gets released. And when the pressure gets released, there are so many good things that are happening. First of all, the thromboplastin is not going back into the circulation, is not causing DIC any further. Number one. Number two, it is inducing the uterine contractions, helping the uterine contractions to be more effective. Now they're directly acting on the baby. Okay, and vaginal delivery is considered when the cervix is also favorable. Delivery is imminent without undue delay or non-salvageable dead fetus. Okay, towards the end of the discussion, I'll be making one chart and I'll be sharing that chart with you. That chart you will not get anywhere. That algorithm you will not get anywhere. It's about certain few points to be seen, and if it's each point, what will you do? Okay, whether it's cesarean or normal, and how exactly would you go forward with a normal delivery. Remember one very important rule. Okay, this is one of the guidelines in induction of labor. Go for Bishop scoring. If the Bishop scoring is less than 6, you need to induce the patient by prostaglandins. Of course, she's not a previous cesarean. If the Bishop score is more than 6 or if it's more than 7, you have to go for ARM followed by oxytocin. Okay. Now, if this patient was a previous cesarean, do not induce her with prostaglandins. Use mechanical dilators. That's how it differs. That's the funda. Okay, that will be the funda for all your inductions. But here, whether you have to do the induction or not, whether you have to go for a normal delivery or not, that will get by my algorithm. Okay, so wait up for the algorithm. I'll be putting it down not only in this PPT, but also in the class so that everybody can see what exactly are we doing with the patient with Abruptio, because that's the class. For placenta previa, I've already told you, if it's grade 1 only, then you can try for normal vaginal delivery. Grade 2, 3, 4, please go for a cesarean section. There's no doubt about it. Vasa previa, cesarean section. So the question is only for abruptio. So abruptio, like I said, depends on 4 factors: maternal stability, the cause, the fetal status, and the gestational age. Of course, in the bishops. Now, ARM, like I said, it does beautiful things, but let me just tell you that. Reduces the intrauterine pressure. That's one. Then it induces good uterine contractions. Number 2. Then it reduces the thromboplastin going back into the circulation, so it reduces the DIC trigger. And vaginal delivery is considered when cervix is favorable. Delivery is imminent without undue delay. Vaginal delivery is better option over cesarean whenever possible, and appropriate decision needs to be taken for the same. Prostaglandins are strictly to be used for induction with poor cervical score and never for augmentation. Okay. Prostaglandins can have an idiosyncratic response and that can lead to hypertonicity, excessive thinning of the myometrium, especially in the lower segment, and uterine rupture. So therefore, they have to be used with proper monitoring with appropriate titration. Oxytocin can be used for augmentation under close vigilance. That is very important because they've told you this thing not to be used. So then what has to be used? Oxytocin. Second stage of labor can be a precipitate one or prophylactic use of forceps or vacuum. That's very important. Second stage, you can use prophylactic forceps or vacuum. Episiotomy should be given only when indicated, as DIC can cause genital tract hematomas. Active management of third stage of labor should be the norm and practiced aggressively. Neonatologist and anesthesiologist should be present to resuscitate the baby, and the baby can be asphyxiated, and the mother may also need immediate exploration or analgesia. PPH is very common in abruption, especially in the presence of covariate uterus, and aggressive use of uterotonics should be undertaken, along with tranexamic acid. See, tranexamic acid has to be spoken out. Then, cesarean delivery may be considered in case of jeopardized but salvageable baby. Okay. A compromised maternal condition, poor cervical score with the possibility of prolonged labor, and prolonged labor with the evidence of fetal jeopardy. So these, may be considered in cases of, number 1, jeopardized with salvageable baby. Number 2, compromised maternal condition. Number 3, poor cervical score with the possibility of prolonged labor, and prolonged labor with evidence of fetal jeopardy. This is where you will consider, cesarean section, and you are going to be talking like this in your Viva as well. So you will consider cesarean delivery in case of abruption in jeopardized but salvageable baby. So whenever you have a fetal distress but just a salvageable baby, that means I'm talking about more than 32 weeks. A compromised maternal condition. Okay. A poor cervical score with the possibility of prolonged labor, and prolonged labor already with evidence of fetal jeopardy. Okay, this is placenta previa and placenta creta. I'll be taking a separate class on it. So, well, we're not talking about this. All right, guys. So, well, I think that's the max that I wanted to talk about. And now let's speak about the immediate postpartum care. Close vigilance for fetal and maternal condition is essential. So we do not want, just give me 2 minutes. Okay. So, yeah, I was telling you about be very sure of looking forward to a postpartum hemorrhage. This is what we're looking forward to. A close vigilance for maternal and fetal condition is essential to avoid any immediate long-term morbidity. Appropriate fluid therapy. Okay. Avoidance of pulmonary edema, correction of blood parameters, control of DIC, and prevention of PPH, especially in the first 24 hours with appropriate oxytocics. Very, very important. Urinary output, ensuring optimal renal function, prevention of sepsis. All this is very, very important. So let me just put it down as a point. Appropriate fluid therapy is very important. Control of DIC is very important. Prevention of postpartum hemorrhage is very important. And prevention of sepsis is very important. And appropriate therapy in the period helps overcome many serious consequences. So all this becomes very important postpartum. Encourage the breastfeeding in the female and look forward to her general condition. Make sure that your MDT team is involved here as well, so that the patient can be given complete one-to-one care. And with this, I finish abruptio. I'm still to explain to you placenta previa and placenta preta syndrome, because there are latest guidelines on that, and that will become as my recent advances along with my live classes. Now, if you have any doubt regarding this, please feel free to throw it up at me. Otherwise, I'll be making this algorithm right now and I'll be posting it on the channel also and in your PPT as well. So that will help you understand the exact mechanism of how to manage abruptio. Abruptio, not placenta previa. Placenta previa, I've told you. So whenever the patient is having excessive bleeding, see, when you know that this patient will be taken up for a cesarean section, half the management you already know. But when you have to doubt whether should I say cesarean or should I say normal, we'll try normal vaginal delivery, that is where the problem comes. And that maximum problem will get in abruptio. You will not get it in placenta previa. You will not get it in this thing, vasa previa. You will get it only in abruptio. Because the question of normal delivery is still there in abruptio. Okay, guys. So any doubts, I'm here to answer. Otherwise, mostly your doubts will be answered by my flowchart. Yeah. Is there anything? It's a very basic chapter, guys. All you need to know in abruptio is, first of all, the different reasons of APH, antepartum hemorrhage, the different reasons of antepartum hemorrhage, the classification of placenta previa, the classification as there are for vasa previa also, the different reasons and the risk factors for abruptio, which is over here. Yeah. These are factors for antepartum hemorrhage. So why will you have a placenta previa and why will you have an abruptio? So preeclampsia, fetal growth restriction, non-vertex baby, presentations, polyhydramnios, advanced maternal age, multiparity, trauma, intrauterine infection, all these are the reasons for, these are risk factors for antepartum hemorrhage, and I'll put it from somewhere in the beginning only. Yeah. Okay, guys. So since there is no doubt, we can